A stroke is when there's a sudden focal neurological deficit due to a part of the brain losing its blood supply. There are two types of strokes: ischemic strokes and hemorrhagic strokes. The majority are ischemic strokes, and there are three types: thrombotic, embolic, and hypoxic strokes. Thrombotic strokes are caused by local arterial obstruction due to inflammatory diseases, like atherosclerosis, and non-inflammatory diseases, like fibromuscular dysplasia. Thrombotic strokes affect large vessels, like the internal carotid artery, as well as small vessels, like the penetrating arteries that branch off of the basilar artery. When they affect these small arteries, they're called lacunar strokes, and they typically cause symptoms like hemiparesis, ataxia, dysarthria, and numbness in the contralateral face, arm, and leg. An embolic stroke is when the blood vessel is blocked by an embolus. If it arises from the heart, it's called cardioembolic, and that usually occurs in the setting of atrial fibrillation. That's because in atrial fibrillation, blood stagnates in the atria and can become clotted. That clot can then travel up to the blood vessels supplying the brain. Alternatively, an embolus might dislodge from a thrombus or atherosclerotic plaque in the carotid artery, and that results in a thromboembolic or atheroembolic stroke. More rarely, there might be a paradoxical embolus which dislodges from a thrombus in the veins, like a deep vein thrombosis, and then slips through an atrial septal defect or patent foramen ovale. It enters the left atrium, and from there it can head off to the blood vessels supplying the brain. Finally, there's hypoxic stroke, which is sometimes called hypoxic ischemic injury, which develops when there's systemic hypoperfusion or hypoxemia. This commonly occurs in infants due to ischemia during birth, but can also be due to things like septic shock or drowning. Now, the minority of strokes are hemorrhagic strokes, where a blood vessel breaks and blood spills out, forming a hematoma that compresses and damages surrounding brain tissue. A hemorrhagic stroke can be caused by either an intracerebral hemorrhage or a subarachnoid hemorrhage. An intracerebral hemorrhage is when the bleeding occurs in the brain itself, and is usually caused by hypertension. A subarachnoid hemorrhage is when the bleeding occurs between the pia mater and the arachnoid mater of the meninges, and is most often caused by a ruptured aneurysm. Patients with stroke typically have a focal neurological deficit, which corresponds to the region of the brain that's affected, which is why the symptoms often suggest the location of the stroke. For example, an anterior cerebral artery stroke affects the feet and legs, whereas the middle cerebral artery stroke affects the hands, arms, face, and the language centers of the dominant hemisphere, including Broca's and Wernicke's area. Finally, a posterior cerebral artery stroke primarily affects the visual cortex, which affects a person's ability to see clearly. Now, in any of these body regions, both motor and sensory fibers may be affected. When motor pathways are damaged, flaccid paralysis develops almost immediately. And then over the following days to weeks, there's spastic paralysis and hyperreflexia due to the hyperexcitable stretch reflex. When sensory pathways are damaged, there's numbness as well as reduced pain and vibration sensation. Both motor and sensory symptoms usually happen on the side that's contralateral from the stroke, except in rare cases of a brainstem stroke, where both sides are affected. When a person comes into the emergency department with focal neurological deficit, the first thing to do is assess the airway, breathing, and circulation, especially if the patient is unconscious. Sometimes, intubation might be needed, especially if there's a decreased respiration and muscular airway obstruction. Hypoxic patients should be given supplemental oxygen and have monitors to ensure that their oxygen saturation remains above 94%. If a stroke is suspected, it's important to check glucose levels and the following blood tests: CBC to check the platelet count, PT, PTT, INR, and fibrinogen. Cardiac monitors and ECG should also be utilized to look for arrhythmias like atrial fibrillation. Stroke therapy is extremely time-sensitive, so it's best not to wait for the results of the tests unless thrombocytopenia or anticoagulant use is suspected, because of the risk of bleeding. Next, a quick history can help distinguish stroke victims from stroke mimics, which include complicated migraine, seizures, and brain tumors. Patients with complicated migraine will present with preceding aura, usually a strange light or smell, headache, and they'll have a history of these events. Patients with generalized seizures usually have a postictal period, which may include weakness of one side of the body, which can mimic a stroke. This is referred to as Todd's paralysis. Patients with brain tumors will often have a gradual progression of symptoms and can also have seizures. Usually the symptoms of stroke occur suddenly and progressively worsen over minutes to hours. In particular, a subarachnoid hemorrhage classically presents with the worst headache of a person's life. Next up, a full neurological examination using the NIH stroke scale can help assess the severity of the stroke. Points are given for any deficits in 11 specific categories with a maximum score of 42. The 11 categories are level of consciousness, horizontal eye movement, visual field test, facial palsy, motor arm function, motor leg function, limb ataxia, sensory deficits, language skills, speech, and extinction and inattention. In addition, some specific physical exam maneuvers include checking the pulse in the neck, arms, and legs to check for irregularities, because that might suggest a cardiac cause. In addition, the neck and retroorbital regions should be auscultated for vascular brutes, because that can suggest carotid artery occlusions. Next, a non-contrast computed tomography, or CT scan, is done to help differentiate between an ischemic and hemorrhagic stroke. Contrast should be avoided to prevent mistaking contrast for blood. Blood on the CT shows up as white, or hyperdense, and indicates a hemorrhagic stroke. The absence of blood indicates ischemic stroke. An MRI is more sensitive than CT for detecting both ischemic and hemorrhagic stroke, but a CT is usually safer and easier to obtain acutely, so it's usually the imaging method of choice. Small subarachnoid hemorrhages can be missed on the CT due to the small amount of blood. So if it's suspected, a lumbar puncture can be done to look for red blood cells in the cerebrospinal fluid. If the blood has been in the CSF for a few days, then the fluid may appear yellowish due to the heme getting metabolized into bilirubin. This is called xanthochromia. If there's a hemorrhagic stroke from severe hypertension, there's usually a homogeneous appearing hematoma on CT. Alternatively, if there was recent head trauma, then blood might appear in a pattern consistent with the injury. In an ischemic stroke, the treatment of choice is thrombolysis with recombinant tissue plasminogen activator, or RTPA. The ischemia is most severe in the core of the ischemic area, where the cells die first, and slightly less severe in the surrounding penumbra, which gets collateral blood from other blood vessels. But if the blood flow isn't reestablished within a few hours, cells in the penumbra will suffer irreversible damage and die, causing long-standing brain damage. RTPA focuses on the cells of the penumbra, which is why it is time-sensitive and should be given within 3 hours of symptom onset for elderly individuals, or those with diabetes, and within 4.5 hours for other individuals. This time is calculated from when the patient was last seen healthy. So if a patient went to bed at 11 p.m. healthy and woke up with symptoms of stroke, the time begins from 11 p.m. RTPA is administered intravenously and dissolves blood clots throughout the body, so it can potentially cause serious bleeding. In fact, in ischemic stroke where blood vessels are fragile and damaged, giving RTPA can lead to hemorrhagic stroke. So with that in mind, some situations where RTPA shouldn't be used include when an individual has an INR of 1.7 or above, has a PTT of 15 seconds or above, has a blood pressure of 185 over 110 or above, has gotten heparin in the last 48 hours, has had surgery in the past 14 days, has had gastrointestinal hemorrhage in the past 21 days, has had a previous ischemic stroke or head trauma within the past 3 months, or if they have a high risk of hemorrhage, like having a platelet count below 100,000. Finally, if RTPA is given to an individual, then aspirin should be given 24 hours afterwards to avoid an increased risk of bleeding. Now, in addition to RTPA, individuals that have an occlusion in the anterior cerebral circulation, which includes the internal carotid arteries that flow into the anterior and middle cerebral artery, may also get a mechanical thrombectomy if it's within 24 hours of symptom onset. Alternatively, if there's an occlusion in the internal carotid artery, or proximal segment of the middle cerebral artery, then a thrombectomy with a stent retriever can be done if it's within 6 hours of symptom onset. Finally, if no RTPA is given and a thrombectomy isn't done, then individuals should be given rectal aspirin immediately. Now, if the stroke symptoms resolve over the course of minutes to hours, and there's no ischemia on the MRI, then it's considered a transient ischemic attack, a TIA. The evaluation of a TIA includes getting a CBC, electrolytes, glucose, lipids, and an ECG, CT, or MRI within 48 hours, as well as angiography and carotid ultrasound, which can help determine the cause of TIA, like embolism or carotid artery stenosis. With TIA, there are no visible infarcts on CT or MRI, which can help confirm the diagnosis. A TIA is managed by figuring out the ABCD2 score, which evaluates the risk of subsequent stroke after having a TIA. ABCD2 takes into account age, blood pressure, clinical features of TIA, TIA duration, and diabetes. Patients with a low score of 1 to 3 don't require hospitalization unless there are other indications like atrial fibrillation, while patients with a moderate score of 4 to 5 or a high score of 6 to 7 should be hospitalized and monitored for a day. There's no acute treatment that's given, and the long-term therapy is the same as for any other stroke. In a hemorrhagic stroke, anticoagulants and antithrombolytics aren't given because they can worsen the bleeding. Patients with subarachnoid hemorrhage are given the calcium channel blocker nimodipine to prevent vasospasm, which sometimes occurs in blood vessels that get irritated by the hemorrhage. Treatment is usually surgical, meaning that a coil or clip is usually used to block off the broken blood vessel, and a craniotomy is often needed to relieve the elevated intracranial pressure from the hematoma. In all patients with ischemic stroke, loss of autoregulation occurs and permissive hypertension is allowed to prevent hypoperfusion. This must be balanced by keeping the blood pressure from going too high, especially after TPA, to avoid reperfusion hemorrhage. In an ischemic stroke where parts of the brain aren't receiving enough oxygen, cerebral autoregulation kicks in, and the brain elevates the blood pressure to increase tissue perfusion. Before RTPA is administered, blood pressure should be below 185 over 110. And after RTPA is given, the blood pressure should be kept below 180 over 105 for at least 24 hours. For patients that weren't given RTPA, or if the patient suffers from cardiac disease, then blood pressure should be kept below 220 over 120. In a hemorrhagic stroke, the blood pressure has to be high enough to perfuse the brain, but it's important to keep the systolic blood pressure below 140 to prevent further bleeding. Typically, either the beta blocker, labetalol, or the calcium channel blocker, nicardipine, is given to attain the desired blood pressure. In addition, individuals are usually kept NPO, meaning that they can't eat or drink until they get a formal swallow evaluation. That's because dysphagia is a common consequence of a stroke, and it can lead to aspiration pneumonia. If there is dysphagia, patients are usually given liquids through a nasogastric tube until they're able to swallow normally. Strokes can also result in increased intracranial pressure, or ICP, causing symptoms like headache, vomiting, and papilledema, as well as the Cushing's triad, which includes hypertension, bradycardia, and irregular respirations. To alleviate the increased ICP, the head should be in neutral alignment with the body and should be elevated to about 30 degrees. Increased intracranial pressure can also be treated by inducing brief hyperventilation, which causes cerebral vasoconstriction. But prolonged hyperventilation can worsen ischemic damage, so it should be done carefully. Finally, mannitol, which is an osmotic diuretic, can be used to help decrease the ICP. Once patients have received acute therapy for a stroke, the focus shifts to preventing another one. With ischemic stroke, embolic strokes often emerge from the heart, so in addition to the initial ECG, ambulatory cardiac monitoring can be done over the following weeks to look for a potential source of an embolus. This can be done with an internally placed loop recorder or a prolonger Holter monitor used for up to 30 days. If there's evidence of atrial fibrillation, then it's assumed that a blood clot has formed in the left atrium. And anticoagulation therapy with warfarin and a direct anticoagulant like rivaroxaban should be started to prevent another blood clot from forming. These individuals, as well as those with valvular disease, endocarditis, and myocardial infarction, should get long-term therapy with antithrombotics like daily aspirin to prevent an embolic stroke. Individuals with severe intracranial stenosis, based on an MRI or CT angiography, should get daily clopidogrel for 90 days. Echocardiography is also used to locate a source for an embolic stroke. If a patient has a carotid bruit on auscultation, or has a history of peripheral vascular disease, or has coronary artery disease, then both carotid arteries are assessed with a carotid ultrasound. If there's carotid artery stenosis that occludes 40 to 69% of the lumen, then an individual is told to make lifestyle adjustments, like a better diet and an exercise plan. If the stenosis is 70% or greater, and the patient is symptomatic, then a surgical stent is placed or a carotid endarterectomy is done. That's where atherosclerotic plaque is surgically removed from the carotid artery. Specific studies, like hypercoagulable studies for protein C or S deficiency, plasminogen, antithrombin 3 levels, and antiphospholipid antibodies can be checked because they're all associated with thrombosis. For hemorrhagic strokes, an MRI or CT angiography is usually done 4 to 8 weeks later because at that point, the blood has been mostly reabsorbed and it may be possible to see underlying vascular malformations or evidence of a brain tumor. Underlying factors like hypertension need to be controlled because they're risk factors for subarachnoid hemorrhage and ischemic stroke. Also, hyperlipidemia and diabetes need to be controlled because they are risk factors for ischemic stroke. Finally, quitting smoking, eating a healthy diet, and exercising regularly are all important ways to prevent a future stroke. Alright, as a quick recap, stroke presents as a focal neurological deficit, usually involving a motor or sensory pathway or affecting vision or speech. Time is critical, so a non-contrast CT should be done to determine if it's ischemic or hemorrhagic stroke. Therapy for hemorrhagic stroke is surgical, or supportive therapy if the hemorrhage is small. RTPA for ischemic stroke should be done in the first 3 hours for appropriate patients. Large artery occlusions in the anterior circulation can be treated within 24 hours of onset symptoms by mechanical thrombectomy. When the patient is stable, ECG, echocardiography, carotid ultrasound, blood, and other tests should be done to discover the etiology of the stroke.